Hey guys, it's Rex. I want to quickly remind everyone of an upcoming conference that's one of my go-to events of the year, every year. It's also the best named conference in our space. It's Qualapalooza. It's put on by our friends at Rise, who are collaborating with us on season 1 of Beyond Quality. It's being held June 28th through the 30th at the Omni PGA Frisco Resort and Spa just outside Dallas, Texas. We'll be discussing and breaking down the most recent regulatory insights on STARS, HEDIS member experience. And Qualapalooza doesn't just focus on STARS. It brings topics like Medicaid, interoperability, and digital quality into the conversation. And the format leans interactive. Think roundtables, measure level work groups. If you're in the healthcare quality world, I highly encourage being there. If you come, I'll see you there. Thanks. See you at Qualapalooza. Quality improvement in healthcare. It's typically described as a framework for systematically improving care. In reality, it's an endless struggle to align policy, data, and processes with human behavior. Join the RWC team and guests from across the industry as we tackle the toughest challenges facing quality today. From culture to capital, from strategy to technology, join us as we go beyond quality. Hey everyone, welcome back to Beyond Quality. I'm your host Rex, and today we're discussing one of the most underestimated levers in all of healthcare quality, and honestly, one that doesn't get nearly enough airtime in the managed care space, period. We're talking about health literacy. Now imagine your goal is to improve the Medicare star ratings at your health plan. You've invested in an outreach vendor, you've spent weeks building outreach workflows, drafting and revising scripts, coordinating the work with all these cross-functional departments. What happens to all that effort when the person on the other end of the phone doesn't understand what they're being asked to do or why? That's a very basic example of the health literacy gap that we face. And for many different segments of your members, it impedes quality improvement work every single day. So today we're exploring health literacy not as a soft skill or a nice to have thing, but as a quality infrastructure issue. Joining me today are two people. First is my co-host and colleague, Jennifer Nguyen. Jennifer's a consultant with RWC, and I'll let her tell a little bit more about herself in a second. Second is the best person on the planet to help us understand health literacy. Helen Osborne is the founder of Health Literacy Consulting, the author of the award-winning book Health Literacy from A to Z, and the host of her own long-running podcast series, Health Literacy Out Loud. Jennifer and Helen, thanks so much for being here. Welcome to the show.
Thanks so much for having us.
Yeah. Can each of you give just a little more background on yourself so our listeners know a little more about you? Jennifer, do you want to start?
Yeah, happy to. So I am a quality improvement consultant with RWC. I've been here a little bit over a year and a half now. Before joining, I spent several years on the health plan side as a STARS leader at a local regional plan in the Pacific Northwest, where I led the full STARS program. Before that, I worked across quality, supporting all lines of business. I also had a brief stint in the nonprofit sector side in patient education and advocacy. My background is in public health and health education, and that background really shapes a lot of how I think about quality, approach quality, not just the measures and the ratings, but like a genuine lever of improving health equity and health outcomes. And that background in public health is really why I have such a deep interest and love and passion for health literacy. So I am beyond excited that we have Helen here with us today. So yeah, Helen, please introduce yourself a little bit too.
Well, thank you for inviting me to be part of this for both of you. My background is I'm an occupational therapist, and I worked in psychiatry for quite a while. And I also have a degree in education. So in my hospital and outpatient days as a clinician, I was always at that intersection of health and teaching. And I was working at a small community hospital in Boston in the 1990s. And in 1995, I read an article that's in JAMA, Journal of the American Medical Association, about something called health literacy. Like, I never heard that term before. It was by Mark Williams et al., and it was a research paper. And in the research findings, their conclusion was that more than half of the adults in this country struggle to understand written health information. Well, I was overseeing all our patient teaching program, and I looked at their handouts that looked really good. They looked nice on a piece of paper. We had good information. We'd use them in our teaching programs. And then I looked more closely at our patients. Our patients were from all languages and lands and levels of educational attainment. And when I saw them, they also had a major mental illness. And it was like the clunk on my head. I got it. Just because I wrote it, just because it had great information, just because it looked good on the piece of paper, did not mean that people could necessarily understand. And that started my journey in health literacy. I soon left my clinical practice to help answer that question I still have 30 years later almost. Okay, I get it. What can I do? And I've expanded it to what can we do? And that has led me down all this amazing opportunities I have had trying to answer that question. What can all of us do to help improve health understanding? So I'm delighted to be talking with an audience, talking about the quality part of this and how it really should be part of our everyday infrastructure. So thank you.
Yeah, it's such an important one, and Jennifer, maybe we need to propose it's a STARS measure, right, in the future, specifically around health literacy. Like it feels like it could be, right?
Yeah, no, absolutely. I don't know what our health plan partners will think about us proposing new measures, but I'm all for it. So I mean, I would love to dig into that a little bit more, Helen. You know, you've been in health literacy for so long now, really writing one of the key literature pieces in the field. I'm curious, from your perspective, you know, when did you actually see the shift of, you know, others in the healthcare field, not the folks in the health literacy community, so like the clinicians, the insurers, the quality leaders, when did all of the rest of the healthcare field really get a hold of this health literacy concept like you did, that it wasn't a patient issue, that it's a systems issue, that we need to band together and do something about it? What do you think? When was that little turning point, or has it really taken off yet?
It's growing, it's evolving, it's constantly changing. That paper I told you about with Mark Williams and others, it was about a clinical encounter between one doctor and one patient. That's where health literacy got started. The term health literacy, and there's also a story about how that term came along and is it even the right term. But it was about that singular medical encounter. Well, that was 30 years ago. Healthcare encounters have changed so much now. It's not necessarily a doctor. It may be a team. It may be a whole group of providers or communicators, or in the clinical realm in public health like you're in, or in the community wherever health happens. And we're also not talking to just one person at a time anymore. Lots of people are bringing family members, their caregivers. There's a whole constellation on each side. So I think that's part of the shift that medical care has changed over time. I think also that there's been a gradual adoption now worldwide of what health literacy is and why it matters. Yes, it's, as far as I know, it started in the United States, as I said, in that medical encounter, but it has grown and morphed and changed, and groups everywhere have come up with their own definitions because it took a while until we got to an okay place with the definition of health literacy. So it has morphed and changed. I can't pinpoint when that really changed, but we are getting there. An acknowledgement of where we are has to do with the definitions. Do you want me to speak about that a little bit?
Yeah,
Sure.
I would love to.
Okay. In the early days, health literacy was, and I talk about, 30 years ago, we needed some kind of a definition. And when I say we, I'm not the first that came up with it. Obviously, there was that one research paper. There was also a book called Literacy and Health by Doak, and Root. But that was really about it. I'm certainly an early adopter on this. But back in the early days, some people had to come up with a definition. And the definition they came up with had to do with the patient's ability to read, understand, and act on health information. That never felt right to me, but I guess it was a place to start. Over the years, with gradual understanding about health communication and abilities to understand and speak in a way that people, present information in ways that is understandable, it has changed. I really like how it is represented. The change came up in the public health document, Healthy People 2030. And I hope that your listeners know about that. Mm-hmm. They now have the definition of health literacy, and it has changed from that original one that kind of missed the mark. I think it was good enough in the beginning. In that, they have two definitions, and they go in tandem. And people can find this by going to Healthy People 2030, but I'm looking at it right here so I get it right. There's two definitions, are personal health literacy and organizational health literacy. Personal health literacy is defined as the degree to which individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. And that's pretty good. But that's putting the emphasis on the individual. I really think it's changing more to systems too. And this parallel definition in Healthy People 2030 is called organizational health literacy. It's almost the same as the one I just read. I'll read this new one with a little bit of a tweak. Organizational health literacy is the degree to which organizations equitably enable individuals to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. It's setting up this system. And I just want to tell you, I needed a definition of health literacy too, all along. So now I started my own consulting business and did writing and teaching and all this good stuff that I've done along the way. And I also told you my background is in occupational therapy, which is all about function. So I needed a functional definition. And my definition then still, I think, holds up today. It may not hold up in a research mode, but I still like it. And the definition is that health literacy is a shared responsibility between patients, anyone on the receiving end of health information, and providers, anyone on the communicating end of health communication. We each need to communicate in ways the others can understand. And when I do this in presentations, I often lock my hands like this. Mm-hmm. We're all intermesh. It's all about that mutual understanding. So the providers, if the patient says, I have pain, the provider needs to understand what that really means. Where the provider, and anyone conveying health information, the provider might say, you need to take this medicine, once a day, and the patients really need to understand, is that in the morning? Is that before meals, after meals? What if I forget? So there's so much more to the basic, what seems so superficial information. So It's all about that mutual understanding on both ends. But the responsibility truly falls on the providers too, and I would think that 100%. Large part falls on your listening audience, the systems.
Mm-hmm. Absolutely. Health literacy is such deep systems work, and I feel like, to your point, we've evolved over the past however many decades. And I think there is finally this shift, this aha moment of, the onus is on the providers, and not just healthcare providers, but, also the operational side. Like, most of our listeners likely are on the operational side. Kind of building the infrastructure, building the programs that, we partner with healthcare providers to deliver. And I love, earlier you mentioned the connection between health literacy and equity, and that's part of the work. So I would love to kind of dig into that a little bit more, like how health literacy and equity are so intertwined. Where do you think healthcare systems, support bringing that together, closing the gaps? Where do you think healthcare systems are still falling, and not, adequately addressing those disparities as they're approaching health literacy, providing, support and care for patients? Can you talk a little bit more around that connection between health literacy and equity, and where those gaps still are?
I could go in so many directions.
Yes, we want to hear all of it.
I want to talk about them. When we talk about people's ability to understand, this is something I feel very passionately about, is about the humanity, that what we all bring to any encounter. And in my book, in my works, in my podcast that I do want to talk about, and I'm going to make reference to that in a moment, it's really understanding the people part, kind of knowing your audience. And health literacy can affect all of us. I certainly have many occasions and many stories I can tell you when I didn't quite get it. If the information was about me or someone I particularly care about, I might get it after a while. But some people are even more disproportionately affected or have even more trouble. And I tend to focus on 6 reasons, but there's more than 6. No one's as, remember I told you I'm good at like writing things on one piece of paper. No one's as neat as all that. But I'd like to talk about factors of literacy. Yes, that is a factor. If you struggle to read or use the printed word, you almost certainly will have trouble with health understanding, because so much of it is in print or on the web. But there are other issues have to do with age. Those of us who are older, certainly, we're dealing with more diseases and conditions and medications, and also life happens, and what that adds to a variable. But also the other end of age. For a young person who goes from going to the pediatrician with their parents to now being independently responsible for their own care, how do they understand and able to use health information? So literacy, age, language certainly is a factor. And in the United States, it's probably everywhere now, we're becoming a more multi-language society. And for someone to be able to speak in English, to talk about the weather or the movies or what to eat, they might be able to do that. But in healthcare, for all those hard how and why, cause and effect, decision-making conversations that are so difficult, it can take a lifetime to be able to talk about that. So language is a factor. Culture, certainly, the context of which we understand information, our values and our traditions and our habits. Another factor that I do not think gets enough attention has to do with the role of disability. And when I talk about if you have diminished or difficulty seeing or hearing or remembering, that's a hard way for information to come in and hard way to get information out. And another factor I always like to talk about, and certainly I have my own experience, has to do with emotion. And emotion, the sheer emotion of being scared or sick or cold or in pain. topped off by all the cognitive challenges that individuals are facing, and then the emotions and the depression and stress and all that is happening in there. Those can all affect health understanding. Now, we don't always carry all of those all the time, but I do like to say that in ways, health literacy is this great equal opportunity employer. At one time or another, we can all struggle to understand health information. So that's one I really like to be true and acknowledge that we're all people. Mm-hmm. And it's not just, health literacy isn't about them. Why don't they get it? And that was part of the problem with that original definition. It put the burden on the receiver of information, but it's not. We can all struggle. It's very human. And for your listeners who might, who chose to do the work that they're doing with health plans and insurance and medicine and all of that, that's great. They chose to do it. But be thinking about the person who had the misfortune to be ill or injured today, didn't ask for it, and didn't go to a school and didn't choose it. All of a sudden, they have to deal with critical decisions and a high level of information. It's a very long-winded way of answering part of your question. We didn't even get to equity. So I'm going to where do you want to go from this? I'm ready to talk about equity, ready to go wherever you want to go.
You paint such a compelling picture, Helen, of how important of an issue this is, right? We talk a lot about whether we're consulting with health plans or sometimes health systems through a health plan, but we talk about the respect that a patient or a member feels and how that plays such an important role in whether they even listen to the provider in the first place, right? So, like the guidance that a provider gives to a patient is heavily influenced by how much respect they're giving to that patient, and I think part of it is ensuring that patient understands what we're talking about, and the fact that you talk about the different languages too. I was at a conference last year, and I can remember someone at our table talked about, I think it was a care manager at their health plan was talking to a patient, and he was taking this medication once per day, but he was having he'd been to the ER 3 times, and they couldn't figure out why. He was having some kind of massive reaction, and they're like he doesn't appear to have any whatever, when plans react with each other, or when drugs react with each other or act right, they couldn't figure out what the problem was. And he was a Spanish speaker as his first language and knew very little English, and they finally figured out that his medication said take once per day, and when he saw once, he read once 11, right? So he was taking 11 pills a day, just because he didn't understand the label, and no one had taken the time to really figure that out. And he was okay in the end, but he had he was under some pretty massive pain for several days or maybe a couple of weeks until they finally figured it out. But we have clients in Hawaii, Puerto Rico, Oregon, Arkansas, New York. I'm just picking some. They all are very different. And you talked about the culture aspect. I mean, not only with countries, but with regions within our own country, right? Like the communication to someone in Hawaii and about and Jennifer used to live there, so I know you know a lot better than me, but the nuances of living there and how to communicate something is so different than the culture in Puerto Rico versus Oregon versus New York versus Arkansas. It just makes me think, or makes me realize how important this is. If I'm a vendor, if I'm a vendor doing outreach to members, I have a big responsibility to, I think, understand these nuances and ensure I'm communicating in ways that health plan members and patients of provider systems need to understand. I just think it's you're painting such a compelling picture. I'll pause there.
If you want to listen to this, and I talk about this, and I'm glad you find it so compelling, one things it can do, and when I speak in person, I take clips of this. I do have this podcast series, Health Literacy Out Loud. I just today, or I'm about to record my 275th episode.
I just listened to the AI episode.
That's the latest one. There's
Yeah.
270 something. But I record ahead of time, like you probably record ahead of time too. But it's what those are. They're interviews. Like you're interviewing me, I interview others. But I interview others who can be talking about their own experiences. And for each of the factors I'm talking about, I have interviewed those. I interviewed a doctor who of family medicine or internal medicine. He's also well known in the health literacy field. He also himself is profoundly deaf. And he can talk about the experience of, communicating as the clinician, but also someone is deaf. And you can listen to that story and listen to Mike McGee tell that story for himself on there. It's just so moving. And for each of these issues, I do have people telling their stories. So none of us are talking about others. They're telling their own story. And the one that I think that had the most meaning to me, especially in the beginning, was, why am I blanking on his name right now? Archie Willard. I consider Archie Willard my hero. Archie Willard was one of the very, very first people I ever interviewed for my podcast series. He has now passed on. Archie Willard I'd see him at conferences and we were on hugging terms, and he was amazing. He also was a speaker himself, and he also spoke to the American Medical Association. He was on his hospital patient and family education committee. He was wonderful. He was wonderful. And Archie didn't learn to read until he was 54 years old.
Wow.
And that's when his wife read something in the Reader's Digest about then Olympic athlete Bruce Jenner, now going by a different name. It's had a few life transitions. But it was not about the Jenner's physical abilities, as an athlete, but about his severe dyslexia. And she said, Archie, that sounds like you. And Archie was tested, and indeed, he was severe dyslexic. So in the podcast with Archie, he can talk about what healthcare is like from his perspective. And I said, because I don't know, it's always been easy for me to read. And I said, Archie, what's it like in healthcare? What's hard? Is it the handouts? Is it the instructions? Is it the checklist? And he goes, all of it. I think if your listeners ever listen to my podcast, I always recommend that one with Archie Willard to hear what it's like for someone who does struggle to read. So
that is profound. Like, we don't ever, I think in the work that we do, right? Like we don't see all of these different aspects. And I love that you're really emphasizing that it's so humanistic and it's so individualistic. And I think, from our perspective, there are certain organizations that, try to impact health literacy in really advanced ways compared to those earlier clients that are still on their way trying to navigate, right? But hearing this story, it's just, we try to approach it. Some organizations do it well, approach it from a systems perspective. Some do it as a blanket perspective. Some are doing it a little bit better in terms of maybe carving out, how to address rural folks versus urban folks and different cultural aspects. But I don't think we ever think about it from this, like, everything's got to be so individualistic. You need to really think about all of the various disabilities that you mentioned, and it's not just a language competency, it's not just a check the box, and I want to really bring this around and connect the dots with folks that might be listening to your health literacy podcast, those that are listening to this quality podcast. I think our quality leaders some might be familiar with health literacy, right? But they're approaching it from this perspective of CAPS and member experience and member satisfaction. So a lot of the things that they're doing in the quality space are, how do we make our materials more patient friendly? How do we make them more, appealing, visually appealing, revising language, and things like that. But I feel like, there are some health plans that are still very early, and they might just be updating forms so that they can check the box, meet, the sixth grade reading level and things like that. From your perspective, I think there's so much that quality leaders can really do to kind of impact this space. But, like, what would you like our quality leaders to take from this podcast? Like, how should they move their culture in their organization to be more forward thinking about health literacy? Like, what is it that we can do if it's just if we're taking one thing away from this podcast, aside from listening to Archie's podcast?
And the other 275 of them.
Exactly, yes.
But I think to make health literacy a habit, it doesn't need to be just one more add-on thing, and it's certainly not one more just checkbox, does this meet the right reading level? And I am happy to opine on why that is not the solution, not a simplest solution, but really, as I sometimes say, to become allergic to these multisyllabic mouthfuls that we do all the time, and turn that allergy into action. And the action is to work toward communicating, whether it's in print, in person, on the web, over the phone, in all our many interactions, to communicate in ways the other person can understand. That's what it's really all about. Plain language, you talk about reading levels, that is one teensy little tool, and that's actually not necessarily the right tool to do it. But certainly your job isn't done by just going to your word processor and spitting out a number that you think, check, now I can go home for the end of the day, my job's done. It's not. It's really making it inside of you, remembering why you do this work. You do this work because you care. And how can you communicate, whether it's plan information or medical information or public health information or community education, you truly want the other person to understand. There are a lot of ways to go about doing that.
Helen, I think of some of the health plans that I've personally worked with, some of the challenges they had that I would put in this category of health literacy, where I've seen some make improvements, such as rather than sending a 2-page letter with tons of text, 300-400 words on it, they changed it to almost like an infograph with just a few call out boxes and some text and some visuals. It felt like it was much more engaging for most people. And then I think about plans that have a portal, right? An online portal where they're trying to make it more visually appealing and understandable and engaging. If someone was looking for best practices on kind of how to do those kinds of things, are maybe those in your podcast, and I've not read your book yet, it's on my list. Where would you point people to kind of learn how to make their materials more engaging?
Well, if you're talking about materials to be more engaging, that's different from the encounter that's more engaging. So I do talk about a variety of different ways to do things, but you're talking about, your question was about materials, so I want to address that. And one way to do that, a great tool to do that, is plain language. And people may be dismissive of that, like, isn't that I hate the term dumbing down, but
Sure.
my response is no, it's smartening up, because we want to communicate in ways people truly can understand. And for those of you, the people you're working with who are counting things and looking at costs and all that, think of how much money it costs if someone doesn't understand the material and then calls or then goes back to the emergency room because they took 11 times the amount of medication because of our choice of word once. So there are a lot of ways to do it, but plain language is described. One of the definitions from the International Plain Language Federation is a communication is in plain language if its wording, structure, and design are so clear that the intended audience can easily find what they need, understand what they find, and then use that information. And there are many components to this. And it's, just because you wrote simpler when you were a kid and you write more complicated now that you're being paid to use big fancy words, or in graduate school you need big fancy words to say the same thing 3 different ways. Plain language, really, again, be thinking of the other person. And plain language includes the organization of the information, the tone, your word choice, yes, your sentence structure, of course, the design, and the opportunity for interaction. And I guess that gets to the gist of one of the reasons I'm not a fan of just thinking your job's done if you know a reading grade level and then you change the word diabetes to sugar because it's got 2 syllables. Well, you miss the mark, but you can pass the test of a readability. That's only looking at one factor. Those reading grade level things are designed by some programmer somewhere for how many syllables in a word and how many words in a sentence. That does not cover this whole longer list I gave you of all that's included and how to make information more usable and understandable.
Yeah. I mean, I love that you're connecting all of the dots across all of the topics, right? Health literacy really is the foundation, and it should, be part of the framework for quality, not just addressing health equity and disparities, but it's that thread that, quality leaders are really trying to hedge towards health outcomes, right? And if we don't see that this is a baseline, if you don't have it, your quality programs are not going to be successful because you're not speaking in a way that is clear, that's understandable, that, our patients and members are, they rely on us for, the clear communication to help support them. We're in the business of patient outcomes, and if we're not communicating clearly and we don't understand each other, we're not going to get there. I love all of the key things that you've kind of touched on, and how important it is across the continuum of care.
Can I ask you a question, both of you?
Please, yes.
How do you know if you've met your quality goals? And where I'm getting at, is that just through a questionnaire or a survey? And if it is, who is able and willing to complete that in a way that's meaningful for people who are making decisions on the results? So I'm turning it back to you to ask about that.
Mm-hmm.
Yeah. Rex, do you want to go, or you want me to take it?
Go ahead.
So the short answer is all of the above. There's health outcomes that are kind of claims based. Did your patients that are eligible for a cancer screening get their cancer screening? That's pretty clear. But the way that a quality leader might address that is they might send a reminder to say, Jennifer, you're due for a mammogram. But, if the communication's not clear, if if what I need to do to go schedule it is not clear, then I might miss that mark. There's also survey questions as well, a member experience. I mentioned CAPS earlier. It's like a 60, 70 question patient experience survey of, how is your interaction with your provider?
I've
How is your
gotten some of
interaction with your
those, yeah.
plan? Yeah.
We all love it.
Exactly. How easy were the forms? And for me, I may or may not answer that survey. It's really long. I don't know why I need to do it aside from the, being on this side of it. My parents would never answer that survey. Their English is not their first language. They won't understand the questions. They won't understand why they need it. A quality leader might send them a postcard or give them a call to say, hey, we really appreciate your feedback. Will you, take the survey if you get it? But how are we in the quality seat really moving the needle on health outcomes, getting preventive services, member experience, answering a survey, if we're not bridging that gap with our patients and our members in a way that really resonates, that they can really understand? So yeah, quality leaders get measured in all kinds of ways, but I think it boils down to what you said at the very start. The work that we do is very humanistic. We need to see each individual, everything about them, so that we can, really support them, provide them the care that they need, in the way that they need.
Yeah.
Surveys are interactive and they're hard to answer. And I sometimes, okay, I'll answer it. And then I go through it and I just give up sometimes. For many reasons, I give up and don't complete that. So it's very hard to write a good questionnaire and a good survey. And there have been some papers about that. And I've probably done podcasts on that. But a long time ago, there was a whole initiative, like how do you evaluate a usable survey? And that's a tool I haven't heard about in years. But I think that's key to the kind of work that you're doing. And I'm just going to make one other point, because we are talking about the people side of this. I had a doctor doing something to me. It was some surgery. I guess his surgery, obviously, it worked. That's great. But I really did not like someone in his office. I felt that I was being dismissed and not spoken to in a respectful or understandable manner. It took me, and I'm in this business, and I have, I have a lot of skills going into this. It took me over a year to have the courage to speak up about why I was trying to avoid this individual wherever I would go. And that took a great deal of courage. And then I felt as though I got dismissed for that. So I would recommend for your listeners, get some training on how to write a good survey. There are people out there who are experts at that one. And then remember the people side. And if you can't remember the people side in healthcare, think about what it's like if you complain about your computer or your car or something that you may not know so much about. What kind of courage does it take to speak up about that and get your needs met?
Mm-hmm. And even courage to... So I have family members who don't have good experiences with one of their doctors, but the process of finding a new doctor. So I think when we think of health literacy, we think a lot about the actual, like, in the moment of receiving care, the communication with the provider, but even finding care, navigating the provider finder online, and understanding, sometimes it doesn't know which plan you have, and you have to type in your plan, and it's very confusing. And then do you have to pick a specialist that's attached to your PCP or not, and yada yada yada. It's very complicated, and not to mention the data's usually not even accurate. But I know many people who won't find another doctor because of the pain involved in trying to find a new doctor. So instead, they just put up with a doctor that they can't communicate very well with, right? So it's sort of a one health literacy problem leads to another health literacy problem. I kind of see those both as health literacy problems, but yeah, there are so many opportunities, I think, specific to what we're talking about today in the whole care journey.
One of the two of you used the term continuum of care. That is a topic that I talk about a fair amount, and I talk about how health literacy is a part of it, and maybe your listeners can find themselves in there. I talk about 4 components. Again, I neatly put them in a neat little package, but it's not necessarily that way. When I talk about the continuum, I talk about wellness, access, illness, and self-care. And maybe your listeners can find themselves somewhere in that. For wellness, I think of issues like disease prevention and health promotion and making your lifestyle choices. For access, that seems key to what your listeners are doing about the health plans and all that, about choosing plans, about paying for care, and also the access of just how do you even navigate our system metaphorically, and how do you navigate the system physically? Like, do you go in the ambulatory entrance of a building, or is that for ambulances? Hard to know sometimes. Illness, that's where health literacy got started. That's where the stories I told you in the beginning were about. And that's really about understanding your diagnosis and your prognosis and making shared decisions and understanding your immediate treatment you need to do, but also self-care. And there's such a small fraction of time is spent in an actual medical encounter, and all the rest of our lives are spent in taking care of ourselves or our loved ones. That's where most health happens. And think of all the health literacy skills that are needed to be able to do that, to know when something is an emergency, and if it's an emergency, where do you go? Which of your many options? How do you handle transitions from one provider to another? What do you do in the middle of the night or on a weekend? What if you forgot your medication? Do you take 2 now instead of 1? All these issues. So wellness, access, illness, self-care. Health literacy happens in all those ways.
Yeah, I've actually had some of those questions, and didn't know the definite answer myself. So yeah, I can relate.
Yeah, I love how you've packaged it up neatly for us there. I mean, honestly, like, what really resonates in all of this conversation is that health literacy isn't just something that sits on the side of the health literacy field, right? It's intertwined, it's ingrained, it should be ingrained in every aspect of care, in care delivery, in receiving it. It's foundational for everyone that is listening to this podcast. And if it's not part of their organization now, hopefully they can listen to this and walk away and listen to your 270 other episodes, Helen. But, really, it's systems work. And, this field has been around for several decades, and we need to really make sure it's ingrained in everything we're doing today. It's not a future initiative, right? We're continuously trying to expand on it and making sure that we're meeting patients where they're at, making sure that it's an actual capability that organizations have, and if they don't, they need to build it now if they want to deliver safe, equitable, high quality care for all of their patients.
I'm glad you and team are all doing this work. Keep going.
Yes,
I think with our listeners, I see this work, being embedded in so many different areas, but whether it's operations or marketing or especially like customer experience, member experience. There are several member experience measures in the quality programs that we advise on that our health plan customers are scored on. And this, I think this fits right in there. And this, I imagine the improvements you could make to your members' experience if you really adopted this stuff aggressively, right? And had a more robust focus on kind of all things literacy. Because Helen, I think if nothing else, I think at the bare minimum, I think you have expanded so many people's definitions of literacy by not just thinking it's, like you said, grade school language or whatever, right? But it's culture and geography and age and disability and all of these different things that affect virtually every member in some capacity, right? And should make us think about this when we're communicating with those people.
You missed the shared responsibility, Rex, where it's not on the patient, it's on us. Yeah.
Right?
It is.
Yeah.
Yeah.
It is. It's on all of us.
And Helen, I know you have a book that we referenced, Health Literacy A to Z. I'm curious if you have another book that you would, not necessarily one that you wrote, but we'll say everyone should read Health Literacy A to Z. Is there another book that you think everyone should read?
Yes. And I heard about this book when I used to go to health literacy back before COVID. Used to go to conferences, and someone would say, "Read this book," and it was like, "Oh, okay, I will." And then I'd hear about it again, okay, I will at some point. And at some point, it was like, oh, I've heard about this so much. I am going to read the book. And it came out a while ago. It's called The Spirit Catches You and You Fall Down. The subtitle is Among Child, Her American Doctors, and the Collision of Two Cultures by Anne Badaman.
Wow. Okay.
It really is a must read. And I was flying from one coast to the other. I had a long flight. I bought the damn book and I read it, and I couldn't stop. I just kept going until I read the whole book. And it's probably one of the very few books I have 2 copies of that I have. And I've probably given away even more than that. And I even heard the author speak about it. It was brilliant. It takes place in Merced, California. Mm-hmm. It's about a Hmong family that goes there, Hmong. They came from Vietnam. And I think they were from the hills of Vietnam. And when they get to California, they're all the story of how they got there. And their precious, precious little daughter, Leah, has severe epilepsy that the family refers to as the spirit catches you and you fall down.
Oh, wow.
And then this book is written in alternating chapters. One chapter from the family's perspective, one chapter from the medical record. And it goes from their understanding of illness. The medical team understand it a certain way about epilepsy and all of that. The family understands it that maybe someone slammed a door too loud. Mm-hmm. What do you do for little Leah? And the interventions there. How do you diagnose this? How do you treat this? It's so powerful.
It sounds like it, yeah.
And that is the clash of the two cultures. Mm-hmm. In fact, I once had the opportunity to interview the author. I was moderating a listserv discussion about that. I just felt so honored to be able to do that. Mm-hmm. And interestingly, this book, when little Leah died, she wasn't little anymore. She grew up, I don't know, maybe in her 20s or 30s. I don't remember exactly why. Her death was on the front page of the New York Times.
Oh, wow.
It is definitely. I can see the look on your face. It looks like neither of you have read this book.
Yeah.
No, I've never heard of it. And I read a lot, but I will add
and
this
this
to the
book,
list
it didn't
for sure.
just come out. It's about 30 years old.
Yeah.
I really recommend it to you and all your listeners. To me, that just stuck with me, that I don't know who's right.
Right.
My work is in the medical field, and that's one way about it. And I appreciate the role of different culture. I'm not Hmong, but I understand, fascinated learning about it. And I think it was so powerful that if I had to recommend one book, this would be one. And if they want to read Health Literacy from A to Z, go for it. That book's been around. I have many editions of it now. The latest one, it includes a lot of stories from my podcast as well. And that's highly used in health training programs. And students tell me they really value that first person account. It's not only what to do and why to do it, but a story or a vignette like I shared with you a little bit. Those seem to really resonate with some people about why it really matters, not just academically or research policy wise, but on the people side.
For sure. Last question. Where can people find you if they want to follow you or learn more about you?
Well, one sign that I've been doing this a while is my domain is healthliteracy.com.
Yeah, you have to pay some money for that right now if you try that. Right?
I get little notices about, you want to sell it? You want to sell it?
I'm sure.
When I got it, it was $35 because nobody was buying domains and I didn't even know why I needed one. And someone in my family said, it's $35, just get it.
You should buy
So healthliteracy.com, Helen at healthliteracy.com, and my podcast is healthliteracyoutloud.com. And both sides kind of interchange and you can click from one to the other. So, so anyway, and then if they ask you, if they go back to you, I hope that you will give them my contact information.
We will, we will share these snippets of this episode on LinkedIn. We will tag you. We will put your contact information there. It'll also be on YouTube, but we'll share all that definitely with our listeners for sure.
Good.
Yeah, thank you so much, Helen. Thanks, Jennifer. Great conversation, very important conversation. Look forward to getting this out there. And thanks so much, listeners. We'll talk next time.
Bye.
Thanks so much, Helen.